some new members that joined today that can come and join the force to develop Busoga and ensure a thriving Busoga, as you have explained. So without wasting much time, I'm going to go to introduce our speaker for today, who is Dr. Ampreire Immaculate. Dr. Ampreire Immaculate is a Ugandan medical doctor with a Master of Science in Epidemiology and Biostatistics. She has grown her career serving as a frontline medical doctor for her first 6 years since 2006 after graduating in 2005. Dr. Ampreire joined the public health field at the Ministry of Health in 2011. Her day-to-day activities at the Ministry of Health dealt with development of policies and guidelines, planning, coordination with partners and districts. She conducted supervision and capacity building on cross-cutting issues in the sector. Her role as a senior medical officer at Uganda National Expanded Program on Immunization at the Ministry of Health revolves around conducting planning meetings to engage and orient stakeholders and partners to review performance-based assessments, health management information systems, data analysis. She does research to identify mitigation measures on operational components of immunizations. She's in charge of management, service delivery, vaccines, or preventable diseases. She does surveillance, communication, and logistics, and has been involved in the cold chain of the same for the past 10 years. She is a very passionate doctor, specifically biased in immunization service delivery in line with recommendations, and has currently been the focal person for HPV vaccination introduction and HPV coverage improvement. Dr. Ampreire Immaculate, we are excited to learn about your work at the Ministry of Health and cervical cancer specifically today. So we're looking forward to hearing from you. You may unmute yourself and start your presentation.
Thank you, Prima. Good evening, colleagues, and thank you for the kind introduction. And I am privileged to really join the Busoga Health Forum, and particularly sharing on my experience and learnings in HPV vaccination in Uganda. Thank you for the consideration, and I hope you can see my screen and hear me. Prima?
Yes, doctor, we can hear you.
Okay. Yes, we can hear you. You're very live and clear, and we can see the screen as well.
Thank you so much. So today we are sharing about cancer of the cervix and the role of HPV vaccination in preventing cancer of the cervix. How do we access the vaccination and how we are performing as a country, and what can we do to continuously improve our coverage in Uganda. So starting with cancer, really cancer is a disease where the body cells, we know the body is made of cells, and cancer is where these body cells grow abnormally. And this is really showing the normal cells on this side, normal cell division, and here we see the abnormal cell division. And usually when cells get too old or damaged, they die and new cells take place. But cancer cells continue to grow and divide until there are too many, and cancer may start in any part of the body and can also spread to other parts. And we know that cancer is not contagious. So that is what cancer is. So taking to what is cancer of the cervix. So this is when the cancer affects the cervix. So it becomes an abnormal and uncontrolled growth of the cells of the cervix, and it results in wounds, bleeding, and can spread to other parts of the body. In early stages, there may be no obvious symptoms, and signs come usually when the cancer has progressed to an advanced stage. Advanced cancer means that the cancer has affected deeper tissues of the cervix, of the uterus, and has spread to other body parts. Cervical cancer usually spreads by direct invasion of the neighboring tissues, as we saw, the cells, and it starts with the other organs in the lower abdomen, the bladder, the vagina, the rectum, and later others. So the burden in terms of what are we talking about in terms of the burden of disease? By 2020, globally, we had over 600,000 new cases and over 300,000 deaths due to cervical cancer. And by 2018, we had 18.1 million cases. And if nothing is done, these cases will increase to about 29.4 million cases by 2040, as per WHO projections. Cervical cancer is the fourth common cancer after, and the most common cause of cancer-related deaths. And most of this burden is really in the sub-Saharan Africa, and we have 85% of the disease burden in terms of cervical cancer. And unfortunately, only 50% of the countries in the African region have introduced the HPV vaccine for adolescent girls. In Uganda, also, cancer of the cervix is the #1 cause of cancer-related deaths among women, and it contributes to the 50% of the cancer in women, according to the cancer registry. So for those who are non-medics, this is just a simple picture of the female reproductive system. And what we are talking about, the cervix is part of the uterus. This is the womb, and the mouth, what they call omuma wanabana, is just this. This mouth is the mouth of the nabana, and that is what we call the cervix, and that's the subject of the matter. And this, and spreading, it spreads in the organs around this lower abdomen. So most of the cervical cancer is caused by what we call the human papillomavirus, HPV, and it is the most common viral infection in the reproductive tract. And there are very many types of the HPV virus. Like HIV, we have type 1 and type 2. So there are many serotypes, over 200, and only about 15% of these actually cause cancer. Two types, 16 and 18, account for 70% of all the cervical cancer cases seen worldwide, with little regional variation. And HPV also causes other cancers like penile cancers, genital warts, anal cancer, vaginal cancer, and oropharyngeal cancers, but these are rare in the developing world. HPV types 6 and 11 are also been seen to cause genital warts. So the types of vaccine is usually classified based on the serotypes, the number of serotypes targets. So we have bivalent HPV vaccine that targets 16 and 18, quadrivalent, which we have in Uganda, that's targeting 6, 11, 16, and 18. And recently we also have the monovalent that targets 9 serotypes of the HPV virus. I hope I'm not fast. I have so many slides. So basically, how is HPV transmitted? It is a sexually transmitted virus, and it's quite common in both men and women. And HPV infections often do not, like other viral infections, do not cause symptoms and are usually self-limiting. The most common signs are usually small pink red warts that appear in the genital area with itching or burning. And people often acquire it soon after they become sexually active. So what are the risk factors of getting the HPV virus? Early sexual debut among the children, girls or females that start sexual intercourse early are more at risk of acquiring the virus. Females with multiple sexual partners and presence of other genital infections, and also weakened immune systems due to many causes, and commonly HIV/AIDS are risk factors for acquisition of the HPV virus. So once you acquire the virus, the cancer is very slow. It takes up to 10 or more years from the infection to the cancer. And while the infection of HPV is the underlying cause of most all cases of cancer, these infections actually do not always result into cancer. Most of them are short-lived and resolve on their own within 2 years. The issue is persistent chronic infections is what predisposes to disease or progressing to cancer of the cervix. And only about 5 to 10% of the women infected with the HPV develop these persistent infections. So if untreated, these infections cause some changes, cervical changes on the cervix, what we are calling lesions, which can progress to cancer over many years. And these are called precancerous. And that's what we look for when we are doing pap smears and other cervical screening. We are looking for this persistent presence of the virus that may have caused cervical changes at cellular level. That's what we call precancerous. And often that stage is asymptomatic, no symptoms. And this is what this can be detected by pap smears, biopsies, and other visual tests that we have. So this is just showing how the infection goes, how it starts with the initial infection affecting a normal clear cervix, then it's showing how the cellular changes multiply, and how you progress now to precancerous lesions, and then this is what cancer of the cervix looks like. So most of the time, as we've seen, the precancerous lesions, there's no symptoms in terms of early cervical cancer. Symptoms usually appear at advanced stage, and usually you will see irregular abnormal vaginal bleeding after sexual intercourse, after menopause, or irregular menstrual periods, back and lower abdominal pain, fatigue, weight loss, loss of appetite, and vaginal discomfort, and the characteristic foul-smelling discharge that usually leads to stigma and delaying in access of care. So how do we, fortunately, is cervical cancer it can be prevented. It's a very devastating disease, but the good news that for the next generation, it can be prevented with the HPV vaccination. And it can also be prevented through abstinence. This can be promoted, especially in the young girls. And also behavior change, delaying sexual debut, having one sexual partner, and also smoking. As we know, smoking has been associated with many cancers, and also prevention and also early treatment with other sexually transmitted infections. However, most of us who have missed the opportunity to be vaccinated, how can we prevent cervical cancer? This can be done through cervical screening using the different methods we talked about, the famous pap smear and the other visual methods. And if it is early cancer, there are different treatment options that are available, which include cryotherapy and others, and also radical surgery if the tumor is early or localized and has not yet spread to other organs. That's when you can have radical surgery. So why are we talking about HPV? It is the most cost-effective way of preventing cervical cancer. in the African region in our country. And it prevents infections of the HPV virus that has been seen in most of the cases. And also in the African region, we see that only 30% of the women aged 30 to 49 have ever been screened for cervical cancer. So we have health system issues, and we are inadequately prepared in terms of having population-based screening, accurate cancer registries, and access to treatments. So it is better and more effective as a country, as a region, to really invest in vaccination. And also we know the devastating effect of out-of-pocket expenditure and catastrophic spending and impoverishment with treating cancer patients. So that is why we are saying HPV vaccination. This is the vaccine we have in stock. If you go to the field, as we saw, it's quadrivalent. It's we are giving 2-dose schedule 6 months apart, and it fits within our existing cold chain or refrigerator temperature. So the targets in Uganda, we are the entry point, we target girls as soon as they are 10 years, because the greatest impact of vaccination results from high coverage of the girls before their sexual debut, before exposure. The efficacy of the vaccine is 95% against HPV before exposure. So that is why we target the younger girls. You'd say, why don't you go for 15? It is really to before exposure so that we maximize on the effectiveness of the vaccine in preventing infection and also the lesions. So that is why. So where did we find the vaccine? HPV is one of the routine immunization vaccines. We give it with polio, BCG, and the rest at the health facilities and also community outreaches, which may be based in designated places and school setting. So this is the package that we provide as of today. I think most of you might still be thinking of the killer diseases, the 6, the TB, the polio, the diphtheria, whooping cough, of pertussis, and tetanus. But we have moved on and grown. So at birth, we have added the hepatitis birth dose for all children, best given within 24 hours of birth. At 6 weeks, we give the oral polio, we give the injection, the DPT. We now vaccinate against pneumococcal, the pneumonia. This was launched, I think, in Uganda, in Busoga. We give the rotavirus vaccine and the injectable polio vaccine at 6 weeks. Then we have at 10 weeks, we have at 14 weeks, and then of recent, we've added the yellow fever at 9 months with the measles rubella dose and the second measles dose at 18 months. So this is Uganda's routine immunization schedule, and every child is entitled to this at this point in time because of the available technology. So we've had issues of misconceptions, but this is what the information shows in terms of side effects of HPV. And what is really very common is pain on the site of the injection, redness, headache, muscle aches, and tiredness. And also itchy or redness of the skin, joint pains, fever, nausea and vomiting, and rarely you've seen upper respiratory tract infections, dizziness, and other sites reactions like hard lumps and tingling. And we recommend that all the side effects or adverse events detected should be reported to the nearest health facility as part of the adverse drug reaction surveillance with the National Drug Authority. So the vaccine is safe, and the benefit of getting the vaccine outweighs the risk of not getting it, as you have seen. So this is the performance of all the antigens we give. And I'll focus on just look at HPV over the years. And this is the performance, but what you note is really the second dose. We're struggling with the second dose, and we've never hit 80. We've really been struggling. And what's the intervention that we did to improve coverage was in 2019 through the HPV coverage improvement plan, and I'll share what we did that the Busoga Health Forum can adopt to also improve and sustain HPV coverage in the Busoga region. So this is just showing since introduction. You'll see we introduced in 2015, but we started with a demonstration study. This is why you will see a bit of data here, and then the trends over the years. In terms of age distribution, most of the girls are 10. Initially, we had begun with class. We used to go to primary for to vaccinate, so we had different age groups, but you can see the majority was still within the age group. And you note that most of our girls are reached at school. So this is just showing the trends, and the spikes you will note is actually the October and April vaccination, the integrated child health. Our health workers seem to only wake up twice a year, in October and April, as you see. And then this is just a sub-national display to show how we've been doing for the last 3 years in terms of HPV1 and HPV2, but you can see that by and large that HPV1 is doing well, but we're still struggling with HPV2. I don't know where Busoga is. I don't know if there's any district here. It would be good to see where we are as Busoga. I think the Busoga region is okay. Okay. So what we observed at the beginning, the reasons for low coverage, there was inadequate leadership and management involvement and limited supervision. And also at the beginning, we did not involve schools, and yet the girls were in the schools, and we found it easy to find them in schools than waiting for them, for the parents to bring. We struggled with insufficient knowledge in the health facilities and communities, as well as the parents. And also there was also confusion on eligibility, P4, 10 years. So, and also some health facilities cited lack of transport to go for outreaches to immunize the schools. And also the misconception that vaccination for HPV is limited to October and April. So what we did in 2019, we partnered with the Ministry of Education this time around and the school health program, and came up with the coverage improvement plan, which mainly really revived coordination. And this can be mirrored and adopted by the Busoga Health Forum in terms of establishing coordination platforms or reviving what's existing, like the task forces, including the health side, education, and partners to oversee the implementation. We revised the IEC materials and developed tools that we disseminated. And particularly, we developed the health facility routine immunization. This is a routine immunization program where we mapped all the schools to a health facility or a cervical point. And that really was the groundbreaking intervention, as well as providing tools. We did not have a tool at the school. We only had a register at the facility, so we came up with the school register. So another thing you can do with dispatched supervisors, you can dispatch supervisors by sub-county from both health and education side for accountability and follow-up, and also regularly engage district multi-stakeholder performance reviews and school mapping. This can be updated because schools are coming every day and other facilities, so this can be revived, and also following up supervision and monitoring for action. And also continuously mobilizing the masses and providing information. So as Busoga Health Forum, what is our role? To join us in sensitizing communities, schools, and all the stakeholders on vaccination, promoting cervical screening and prevention and advocacy, countering the rumors and misconception regarding HPV, ensuring that all the schools and communities are mapped to service points. This is the bottom line and should be done by sub-county. And I know Busoga already has those priorities, the reproductive health, maternal, newborn, child and adolescent care. You can actually integrate HPV vaccination in the existing interventions and partnerships and for efficiency. And then also checking for the older girls to ensure that they did not miss out. And if they missed out, it is still not late for them to catch up with their doses. So what is key is that HPV is effective in preventing cervical cancer, and we really want all the eligible girls 10 to 14 to be vaccinated. It is safe and effective, and also it's provided free of charge in all health facilities providing routine immunization all year round. And I hope all the women on the forum, you've had your cervical screening, and all the parents who have adolescents, all your girls have received their 2 days of the HPV. Thank you.
Thank you, Dr. Immaculate, for that insightful presentation. There is quite a number of questions for you in the chat, but I also realized someone's hand was up. I think they've lowered it. No, the hand is still up. Let me go with Mr. Jingo Stephen. I'm going to unmute you.
Yeah,
Okay.
Thank you so much. Thank you so much, Doctor, for this nice presentation. It is really nice. But my question or concern is, like you've said about, we are struggling with the second dose. And I know of HPV, and I know last year around Feb 2022, WHO came out with some guidance about the single dose HPV vaccination, but also just next door, our neighbors in Kenya did a study, a randomized control trial about single dose HPV vaccination. And the studies showed that actually the single dose works well, and we all know the advantages of us going into a single dose. So is it something that government of Uganda is thinking about? Number two, now that we know that one dose works, should we sit down and console ourselves that the girls are not coming back for the second dose, yet we know that actually even one dose is enough? Thank you so much.
Thank you, Stephen. Shamim Nantege.
Thank you very much. Thank you very much, Doctor, for the presentation. Actually, I'm one person who is passionate about eliminating cervical cancer in Uganda. I just have a few concerns, and some of them are maybe additions and some of them will be questions. Just part of the addition, you talked about HPV DNA testing as in private setting, but currently even the public settings are taking it on. And the beauty about it, someone can do self-sampling and just takes the sample to the facility for testing. Then the other means of treatment for precancerous lesions is use of thermocoagulator. Actually, of recent, it's preferred to cryotherapy because of its easy mobility. It is a small tool to carry around, and it can be charged compared to the cryotherapy, which needs a big cylinder to move it around, so it gets hectic to carry around their cryotherapy. So thermocoagulators can easily be used in camps. So my question comes in, when we do vaccination for our little girls, does it mean that with time that generation will not require cervical cancer screening, so they're actually safe? Then the other concern was about HPV vaccination. Where I am, we realize most of our health workers actually, either they don't want to give the vaccine or they don't have knowledge about vaccination, and the vaccination gets expired in the stores. As well, the communities, as you said, we still have challenges with communities because of the myths and misconceptions, whereby this also cuts across when it comes to not only in HPV vaccination, but to cervical cancer screening as well. Myths and misconceptions are also really affecting the cervical cancer screening. Then I would really inquire to know, are there any challenges we are facing in the uptake of HPV2? Because even the data that keeps on circulating over the net, HPV1 is taken up, but HPV2 uptake is really, really low. Then the other issue is in immunizing children in school. How do you go about the parents' consent? Like, how do we engage the issue of, because they are below 18 years or below 15, how do we go about the issue of them consenting for the vaccine? Then I'm inquiring if I got my first dose, after how long should, I didn't get the second dose after 6 months. After how long am I qualified to take the second dose or restarting the schedule? Thank you. Over to you, Chair.
Thank you, Shamim. Dewo, we are going to have your question and Doctor will respond before I go to questions in the comment section. Dewo Tiberinda.
Yes, thank you so much. I would like to say thank you so much, Doctor, for that presentation. Many of what I wanted actually to ask have been asked by the prior people that have asked questions. However, to re-emphasize more, she is a focal person in the ministry. I would like to know whether the incidences of cervical cancer in children, in girls, I could say adolescents, whether it's actually alarming or not. Because according to the numbers, it is much happening in older women, 45 and above. It is understandable. However, these women are not eligible for the vaccine unless they do a HPV DNA PCR, and which is actually not widely available in the country. My colleague emphasized that this is going to be available even in private sector, but I don't know whether the costs are subsidized. Then basically, the other question was about the pap smear that has been emphasized more in the regional referrals, national referrals, and health center 3s and 2s. This is a test that is done to women that are older, that probably come with signs and symptoms of probably severe bleeding, maybe lap. And I would really want to ask the doctor if there is any recommendations for the time between the immune suppressed, the frequency of checking for immune suppressed and those that are not compromised, basically with HIV. And my other question would be about some of the questions that I always face with mothers who are actually encouraged to go for family planning. Intrauterine device, the IUDs, most of them have been discouraged by the misconceptions out there that it actually predisposes or it increases the risk of contracting cervical cancer, because during intercourse and there has been emphasis on it by the local population that the risk of contracting HP virus, and then subsequently getting cervical cancer has been high. Basically, those were my main concerns. Thank you.
Thank you, Deo. Before I go to Nicholas, I'm going to request Doctor to respond to those 3 comments. Then I'll take one more round of questions.
Thank you. The first question was on the single dose and the evidence that is emerging. So WHO advisory group, the SAGE, gave their position on that, but it is still being left to countries to decide. And studies are still ongoing, considering that the time it takes from infection to cancer, it would be. They think the studies need more time also to really conclude that a single dose. So more studies are going, some countries have switched, but for Uganda, we have the National Immunization Technical Advisory Group, and it has been consulted to review the evidence and the WHO position and guide the Ministry of Health on either to switch to a single dose schedule or remain with the 2. So, but for now, and actually the single dose usage is off-label by the manufacturer. So they don't want to take any risks of changing So the prescription is still 2 doses. The single dose use is off-label, but it's being left to countries to make that decision. And also, so for now, I would say to avoid confusing the health workers, we are still providing a 2-dose schedule. Then HPV vaccinated girls. Yeah, we've been vaccinating since 2006, following the pilots we had. And these girls are now mothers. So the guidance is every person above 25 should do cervical screening every 3 years, irrespective of the vaccination status. And for the HIV, it is every year. If you're HIV positive, cervical screening is recommended every year. So even with vaccination, we continue screening, and that is what is actually going to measure in the long run the impact of the vaccination. Are we reducing the burden or nothing? So that's why we need that data, and also not to take chances. What is causing the low HPV? There are many factors really in terms, but we think most of the challenge could actually be data quality issues in terms of tracking the girls that started and following them through and how they are recorded. So we have a feeling that part of the HPV-1 excesses may actually be second doses, and it's a data capture issue, which we are trying to resolve with digitizing the data capturing system. So we think it is an issue of follow-up of the data collection processes. Then in the schools, how are we managing the issue of consenting? So when we are launching as the Ministry of Health with the education, we introduced into routine, and what we do is to rely on the school arrangements, because what works for different, it depends on the school case by case. Some schools, it's okay. Some schools have had to first write consent to the parents and inform them for vaccination, so it varies. But most of the schools do not ask for consent actually. It's just prior notification, and then you get a date, and then vaccination. So it's handled case by case. What if you miss your first dose and you take long, you can always catch up with your second dose at any point in time, as long as you're within 1 year. So even after 12 months, you can get your second dose. Then the other question was on incidence of cervical cancer in adolescents. So we don't screen for HPV before vaccination, and we don't screen for sexual history. So we vaccinate the girls as they come. And the women, it's really cervical screening. But off record, we don't target women. But if you want to get your vaccine, you will not have, of course, get a single dose or 2 doses. You'll have to get 3 doses if you're above 14 years. But that is not our target, and we do not screen you to vaccinate. We just give you the vaccine, and that is it. So HPV vaccination does not require prior screening for sexual history and HPV serology. Then I talked about the interval for testing, 3 years for non-HIV and annually for HIV women. Then the misconceptions with family planning. I think that is where the concept of integration comes in, and proper health education. And it would be really very good that when you're inserting an IUD, you give the woman a reward of doing a pap smear or a test, so that you have a baseline that you can actually use to track her cervix, and these are the women who can give testimonies in the communities. So health workers should also use data and integrate IUD insertions with pap smears. Why would you give me an IUD and put a speculum and deny me a screening test? So it's really unfair for you to insert an IUD and not give a cervical report to a mother. So that is why we need to really integrate cervical screening as standard in antenatal, and advocate for reagents, for equipment, and training of health workers to use the best methods available. I think that's what I recall. Prima, over to you.
Thank you for that. I'm going to take one more round. I see someone, Agaba, put his hand down, but okay, Peter Nason, you can ask your question.
Yeah, my question is partially answered because I was going to ask about if there any standard protocol developed by the people concerned so that people at lower facilities could be able to follow when they need to do those cervical screening procedures. Because if I think there's a standard protocol developed that normally put us the job 8 at their work places, they can go through and then they said, since I'm going to do give you an IUD, I can also do this for you. Is it okay? It's a simple procedure. This is what I'm going to do, ABCD. And I think that is what is really lacking at the lower facilities and even those other regional referrals. Probably the knowledge is not reaching them well, so they are not able to do that. Thank you.
Thank you, Nelson. I'm going to sample 2 more questions and we'll be bringing it to a close. Doctor, is there any possible benefit of vaccinating the male child too? Joseph Luembao is asking. And any evaluation of the effectiveness of the vaccine? How many CAX cases are averted by the vaccine? That is Matovu John. You can respond to those and we will close. The other questions will be compiled and I'm hopeful that the team at the Busoga Health Forum can provide some responses and hopefully inbox since everyone has registered and their emails recorded. Thank you, and over to you, Dr. Immaculate.
Thank you. For the boys, yes, if resources allow, there's a benefit because it helps in building herd immunity. Because you immunize the majority and then the chances of acquiring the virus are limited, but the priority is now for the women and the motivation. The vaccine stock is still limited and we are prioritizing the gender that has the cervix for now, but there is benefits of herd immunity in vaccinating the males. In terms of effectiveness, the vaccine is 95% effective in preventing HPV acquisition. I have not read the details of the lives averted for the HPV vaccine, but I would prefer him to read the WHO position paper and get that information. Thank you.
Thank you, Doctor. There's loads of people asking for the CPD link to register to be able to get the points. That has been posted in the chat. Please, you can go there, register yourself so you can be given the points. Right now, I would like to bring the meeting and the discussion to a close. Desmond will be reaching out to all people and hopefully supporting them with the responses to questions that have not been answered. And on that note, I would like to invite Dr. Let me see. Dr. Kaweru Wilberforce, please help us give us some closing remarks from the BHF board so we can send the team to have a restful weekend. Thank you
very much. Thank you very much, Council Prima Kwagala, and thank you for serving the women when you're offering your pro bono services to them. We really appreciate, and thank you for being such a wonderful moderator during this presentation. and we shall always call on you. I know you are part of us. You're a very strong pillar, our board, and we really appreciate your services. And we have benefited this evening also by doing a pro bono modulator for Busoga Health Forum and the entire country. So we really appreciate Madam Prema Kwagala. And for Dr. Ampreire, Immaculate, we work with you. We are really very good, very grateful to have you this evening at Busoga Health Forum. And it was good you to come and throw more light, because some of those concerns really cause a lot of issues in terms of vaccine uptake. And we know that vaccine hesitancy is always a very big challenge. But thank you for coming to Busoga and enlightening the entire country. We really appreciate Dr. Ampreire, and we thank you for the good work you do at ministry. And also me, I know I'm going to work with you for around 4 years. We already started, and I really appreciate your services on behalf of the entire country, Uganda. So I would wish to say thank you very much. May God bless you all. And I wish you all a good evening and a good weekend for God and my country.
Thank you.